First of all, meet the team. We have a couple members of the team in the back, Michelle and Tam. So, the other members of the team, Dr. Blaha is one of my partners, and I have hobbies. One of my hobbies is I enjoy cooking because I enjoy eating. I also enjoy spending time with my kids, occasionally running, gardening, stuff like that. Dr. Blaha's hobby is knee kinematics. And one of the video I have today is one of his. Dr. Hallstrom over here on the right is someone we stole from St. Joe's 3 years ago. And the three of us make up the arthroplasty service at the university. Michelle, who's in the back of the room, is a nurse practitioner. She's been with the arthroplasty service for more than a decade. Tam, who's also back in the back of the room, has been with the arthroplasty service for more than, just hit a decade. We've got Heather, Jean, someone else we stole from the institution across the way, Lindsay, and our administrative staff, Lisa and Bethany. So if you end up contacting us or being involved at least with us in any way, you're going to run across one of these people. So what is a knee? Herb Coffer is up here. Herb, can I pick on you? So and Herb was around when we were thinking about the knee as a hinge. And this is actually a knee prosthesis from what year, Herb?
That would be the 50s.
Yeah, the mid-50s, a Waldius hinge. And this was an actual prosthesis that I think was removed by Dr. Matthews from a patient. And it turns out that the knee is not a hinge. And as much as it looks like a hinge, it's a little more sophisticated than that. And this prosthesis, while it's an antique, and I'd like it not to walk out here, turns out that it didn't work. And basically, when you put a hinge in a person's body and then you ask them to twist and turn and pivot, it didn't work. And it would loosen quickly. And so Herb and Larry and others at the university spent a lot of time and effort trying to figure out what a knee was and how we could effectively replace it. Shortly thereafter, people said, well, maybe the knee works like a 4-bar linkage. And here's your anterior cruciate ligament and your posterior. And that would explain how the complex femur kind of rolls back onto the top of the tibia. And you may have heard an advertisement about the knee that bends and rotates. And even this is really an oversimplification. And the knee is a pretty complex thing. It lets us do all these amazing activities, and 9 times out of 10, it doesn't complain. And I tell my patients when they come to see me and they've got a worn-out knee, I tell them, well, when you're ready to trade in your sports car for something in sort of a sedan version, let us know. Because the knee, when it was young and new, was better than this. And so the question is, what do you do when it's not a sports car anymore and one of it's hurting? And whether you're the heroic soccer player or the weekend warrior, the knees can give you troubles. And again, whenever one of my patients is considering intervention in the knee, I remind them that while it's an oversimplification, the knee is a lot like your knuckle. And if you remember playing as a youngster and you would jam your finger or it would hyperextend, either playing ball or roughhousing with your siblings, even though you caused no significant injury to your knuckle, it was swollen, stiff, and painful for weeks. Now imagine cutting on it and having it be this big. So the knee is so when your sports car is worn out, the question is, can we make it better? So just very oversimplified the knee. What is it? There's bone, there's hyaline cartilage. The hyaline cartilage is that smooth, pearly white surface that caps the ends of the two bones. The meniscus is a fibrocartilage or a rubbery bushing that lives between the round femur and the flat tibia. And then there's obviously all sorts of ligaments and tendons and synovium. And you've got your quadriceps coming down, inserting on your patella, allowing you to extend your knee or do high leg kicks. You've got your hamstrings, and all these work together in concert to make that sports car. Oftentimes, and this is another schematic of those soft tissues stripped away, but It's really easy, especially when you're looking at your own x-ray and you see the arthritic surface. It's really easy to forget that all that other stuff is there and just kind of focus on the hyaline cartilage and the ligaments and the meniscus. But the truth is, while this is another schematic of arthritis, the truth is just because you have an arthritic knee doesn't necessarily mean that you're ready for a new sports car, because there's a lot of other stuff in the knee. And this is just an example of, you've got a bursa here, you've got a bursa here, you've got synovium, this red tissue is the lining of the joint, and you have a lot of other things that live in that knee besides what's evident on the x-ray that can be causing pain. And a lot of times, before you go visit your surgeon or think about some heroic intervention, a lot of times some basic home remedies, some what we call RICE, rest, ice, compression, elevation, little exercise bike, weight loss. A lot of those interventions can really make a big difference. Your physician may order an MRI. I think these are probably overutilized. 9 times out of 10, I was running 4 or 5 years ago. I twisted, I fell, sharp pain in the back of the knee. I knew for sure I had a meniscus. The MRI wasn't necessary, and I limped around for a while and rode the bike and sort of stopped hurting. But the MRI does a good job showing all those other structures that live in the knee. The fat pad and the synovium and all those other things. And probably gives us a level of detail in the knee that's more than we really need. Now, if you're a young person, if you're 20 years old, and your surgeon is really trying to map out a cartilage defect in preparation for something, the MRI is probably much more useful. But if you're middle-aged, like I am, or older, and you simply have a sore knee, 9 times out of 10, a good physical exam can probably, or even just the history obtained at the cocktail reception, can tell you what's probably going on. So what's the diagnosis? The history is going to tell you the diagnosis. The symptoms will confirm that, and then just like in real estate, location is the key. So what is it? Well, the history. It's either it just happened or it's been going on for some time. Acute things that can happen to the knee. I was playing tennis and I felt a pop, and now it hurts when I do this. Well, that sounds like a ligament or a tendon to me, and then it's just a matter of when does it hurt and what things do and don't work. Chronic conditions, those tend to be tendonitis, arthritis, or they can be synovitis, which is very common, or instability. So, if you're middle-aged and when you go to play tennis and every time you go to put weight on the leg, it feels like it's going to give out, that sounds like it might be something instability, and that could be a tendon, a ligament disruption, or something else. If you only have pain when you twist, well, that sounds more like a tear in the cartilage. So again, the history can tell you what's going on. So where does your knee hurt? Is it achy? Is it sharp? Is it with certain activities? When someone comes to see me and they say, I get this pain and it's right in the inside of my knee, a simple question can be, well, does it hurt more when you walk to the back of the store? Does it hurt more to sit when you drive to the store? Or does it hurt more to twist when you're taking the grocery bags in and out of the back of the car? And if it hurts more to walk to the back of the store, that sounds like arthritis. If it hurts more in the car driving to the store, that sounds more like sort of that inflammation of the synovium, especially if it hurts in the front of the knee. But if it really only hurts twisting, taking the bags out of the grocery bags in or out of the car, that sounds more like a tear in the cartilage or a meniscus. None of which necessarily need surgery, all of which can be treated with an exercise bike, some Motrin, a little rest, things like that. Instability. What is instability? We have people who present with catching, locking, cracking, snapping, the Rice Krispies, snack, crackle, pop, giving way, locking. Those are all words that are sort of thrown out. They're used by physicians, they're used by family physicians, orthopedic surgeons, patients alike. And you really have to kind of figure out, what do you mean by that? True locking of the knee is my knee gets caught and I have to take my arm and my leg and I have to unlock it. And if you have true locking of the knee, you probably have a torn cartilage or meniscus or maybe a cruciate ligament injury where the cruciate ligament is getting in the way of the knee motion. If you have giving way, meaning When I go to put weight on that leg and I go to make a turn to do my backhand and playing tennis and my knee gives out, that sounds like a chronic anterior cruciate ligament injury or a chronic ligament injury where your knee's not supporting you. However, if you get catching and grinding and clicking and clunking, that's what I have in both knees, and it's more likely than not. I'm not sure. Herb, can I ask, what is catching and grinding and crepitus in the front of the knee? Do you know?
No, I don't. It's non-specific. It can be a lot of different things.
Yeah, so it's really, we don't know what it is. I have it in both knees. I can hear my wife when she goes up the stairs, and her knees are in better shape than mine. I tell patients, you know, it may be some irregular surfaces on the underneath of the kneecap. It can be some synovium, sort of some irregular synovium that's rubbing over the end of your knee. Keep in mind that the end of your knees is kind of a big knuckle, and when you flex your knee, your little tiny kneecap, like a button in the fabric of the front of your knee, you know, is only part of what's rubbing over the front and the back of that. But locking is one thing. Catches, locks, that's a meniscus. Giving way is another. That may be a ligament injury. And then this grinding is non-specific. Swelling, location and timing. If your nephew or niece is playing sports and later that night their knee swells up like a cantaloupe, they probably have a meniscus injury. If the front of the knee gets puffy and warm, that's more likely just to be synovitis or inflammation of the knee. Your knee telling you that you overdid it and whatnot. So, and then obviously if there's an on-the-field injury and it swells up immediately before the end of halftime, then that's more likely to be an acute ligament tear, like an anterior cruciate ligament. So if it swells up the next day like a cantaloupe, it's a meniscus tear, more likely than not. If it swells up during the game, it's a ligament injury. And if it's just puffiness around the kneecap, the front of the knee, it's more likely synovitis. So location, location, location. It's not just in real estate. Pain in the front of the knee is very common. There are entire textbooks that have been written from the 70s to the present and beyond and before and probably in the future about anterior knee pain. Your doctor might call it chondromalacia or patellofemoral disease or maltracking or a number of things. I call it anterior knee pain, anterior meaning the word for front, because I don't know what it is. I think it's probably synovitis more times than less. It's very, very common. It's very common in adolescence. It's very common in middle age. It's very common as we get older. That is the pain that you have when you sit for periods of time. Driving in the car, it hurts the front of the knees. I have to stretch out a little bit. Going up and down stairs. And unfortunately, because as evidenced by the fact that multiple textbooks have been written about this, we don't have a good answer. We don't know exactly what's causing it. We don't have a good solution. And that's, without a quick fix or a direct answer, that's the sort of thing, these anterior knee pain, don't rush off to surgery. Really work on it, bike, weight loss, anti-inflammatories. Inside or medial knee pain on the inside of your knee. If you have pain there, it's either a meniscus tear, medial collateral ligament injury, or arthritis in the medial compartment. Sharp pain in the back of the knee is a meniscus tear 9 times out of 10, especially if you have that pain sort of twisting. That doesn't mean you need surgery. Doesn't mean you need to go see your sports doctor and have them scope it and trim it out. It just means you have a meniscus tear, which is like a loose piece of trim on that old sports car. If the trim is scratching every time you pull the car in the garage, you might need a little trim job. But if it doesn't bother you and you're getting by, you certainly don't need to rush off to the operative suite. So again, this anterior knee pain. If somebody wants to win a Nobel Prize, go ahead.
Do those tears heal?
They stop hurting. I don't know what happens to them. Maybe the trim bends or breaks or falls off or completes the tear. So anterior knee pain. If someone wants to win a Nobel Prize, solve pain in the front of the knee, because it's so common and we really don't have a good understanding what it is or how to fix it. The patella lives there, and the patella is blamed 9 times out of 10 because you can see a patella or a kneecap on x-ray. I'm not sure the patella is to blame. I think all the stuff around the patella is involved more likely than the patella. That's synovium. That's a fancy word for lining that its only job is to produce a small amount of fluid and cause pain when it gets annoyed and inflamed. It can be just from deconditioning. You know, if we put people into a cast because they broke their tibia, when we take them out of the cast, the front of their knee hurts. When we ask them to stay off of their foot because they broke their toe, when they go back to walking again, the front of their knee hurts. So the front of the knee is sort of the barometer of the leg. When the leg's not doing well, the front of the knee tells you. Prescription, rice, that's not little grains of carbohydrate, that's rest, ice, compression, elevation. But don't rest it too much, because remember that deconditioning goes along with knee pain. So we do want you to get on the bike. Now, 5 times out of 7, when I tell my patients we want you to get on the bike, they say, oh, I do the treadmill. The treadmill is good exercise, it's good for your heart, gets your heart beating, things like that. But you can walk on the treadmill all day long and not bend your knee or use your quadriceps or your hamstrings. So really the best activity for the knee is something that takes your knee through a normal arc of motion, working the kinks out, while gently toning or strengthening your quadriceps, which straighten the knee, and your hamstrings, which bend the knee. And the exercise that does that the best is a bike. If you have low back pain, sitting on a bike with your hands on the handlebars can aggravate your low back pain. So if you have both knee pain and back pain, you may try a recumbent bike or a new step or something where you can sit back and just do that. If you feel like the bike is not enough exercise and you really need to be a weekend warrior, then you can do things like a leg press or other things like that. Now, if you don't have a gym membership and you want to do a leg press, you can just put your back up against a nice smooth object like a door and arch down to maybe 70, 80 degrees and back up. And non-steroidal anti-inflammatories. What are non-steroidal anti-inflammatories? Over-the-counter, ibuprofen, Motrin, Nuprin, Aleve. Are they for everyone? No, they do have some side effects. If you take a lot of them over a period of time or you have kidney disease, they can hurt your kidneys. So obviously you want to tell your physician if you find yourself going through bottles of them. And they also decrease the protective lining of the stomach, so if you're prone for acid reflux or ulcers or other things like that, they could be injurious.
What about the elliptical instead of the bike?
The elliptical is like the bike, but it's a little more aggressive. So yeah, if the bike isn't enough for you and you have access to an elliptical trainer, that would work well. But if you have back pain, the elliptical can aggravate that sometimes. So medial pain. Remember I said that that's either a torn cartilage. Go ahead.
I was going to ask about the anterior pain. If that radiates down to the ankle or the front of your leg, is that still considered, you know, that anterior pain?
If usually anterior, when people have that anterior knee pain, they usually grab the front of their knee like this. If the pain radiates down your shin, it's more likely to be arthritis as well. That anterior knee pain doesn't seem to migrate as much. But, you know, people say, oh, my whole knee hurts. Where does it hurt? Right there. Does it hurt over here? No, it's here. It's the knee. So medial pain. Well, again, if it's an acute onset, you were fine until you took on, you know, your arch rival in doubles, tennis. If it's an acute thing, it might be a meniscus tear. But if it's sort of achy arthritic, you prefer to stay in the car while your wife goes into Costco, it's more likely it might just be arthritis. I can't imagine staying out of Costco, but if there's that sharp acute pain combined with catching, again, maybe a meniscus tear. Sharp pain that radiates to the back of the knee tends to be a meniscus. And again, if you have pain with twisting, is it more twisting or walking? But notice the treatment's the same. You know, that a little bit of rest until it quiets down, exercise, bike, anti-inflammatories. Pain in the back of the knee, people will say, oh, I have a Baker's cyst. Baker's cysts tend not to hurt. What tends to hurt in the back of the knee is a tear in the cartilage. So if you have pain in the back of the knee, whether you have a Baker's cyst or not, it's more likely, especially with twisting, it's more likely than not a meniscus tear. But again, you know, the treatment's the same. Don't rush off. While I make my living being a surgeon, don't run off and see your surgeon every time your knee hurts. So arthritis. I'm an arthritis surgeon, so I have to talk about arthritis a little more than the rest. Non-operative treatment. Again, same as the other stuff. Rest, a little bit of rest, bike, condition your quads, get your knee going through a range of motion. So these are some x-rays. The middle view here is the patient standing, looking at you, and you see the joint space on the inside of the knees, on the outside of the knees. Here's the lateral view of the knee. You can see the kneecaps on the outside. And if you notice, the kneecaps are closer to that bone than the rest, and you can see this person has quite a bit of arthritis underneath the kneecap. This person has what I would say is mild, I would say moderate tricompartmental arthritis, most significantly involving the kneecaps. My advice to this person, how do you view your car? This car may still drive fine. No matter what the x-rays, how the x-rays look, the car may still shift in and out of all the gears, may outperform the Ford Taurus, and just because you go to your surgeon and they say, well, you've got arthritis, doesn't mean you need to trade this beauty in. So what if you've decided it's time, you really want surgery? Well, the two arthritis surgeries that work well are partial knee replacements and total knee replacements. That's not minimally invasive and old-fashioned. That's literally a partial knee versus a total knee. What are the advantages of a partial knee? When it works, it feels great. Feels like that sports car again. The problem is it's technically pretty tough to do, and it really only works, that is, functions 90% of the time. Those are good odds, but it's not like a hip replacement that works 99% of the time. How about a total knee? Well, if you talk to your doctor, it works great 98% of the time. What's that mean? That means 10 years after you have it done, when you look at the x-rays, the surgeon's patting himself on the back, him or herself on the back and saying, your x-rays look great. The problem is, when you have the entire inside of your knee replaced with metal and plastic, vis-a-vis something like this, it doesn't feel like that sports car anymore. All the arthritic surfaces have been replaced with metal and plastic, and the knee is brand new, except for that, oh, that's right, that synovium and those ligaments and all that other stuff that may have been causing the pain to begin with. So a total knee works great, functions, survives, doesn't need another operation almost all the time. But when you ask the patients, when the surgeon leaves the room and the data collection person has them fill out their questionnaire, they're going to check the box, I regret having the surgery, 10 to 14% of the time. And that's the main reason you need to put this off as long as you can and try the bike and the Motrin and everything else, because you don't want to be the person that regrets it. So what to expect from knee replacement? Well, if your x-ray looks like this and your knee looks like that, as long as you don't want that again, your surgeon can probably get you that. So here's just a real quick look. So what's the partial knee? You know, this person, you can see obviously most of their arthritis is just on the inside of the knee. So if your x-rays look like this, and if you're thin, how thin? Thinner than me. And if all your pain is there, then this little tiny operation with just a runner on there and like that is a great way of getting back into shape. It is not for young, vigorous, heavy-set people that want to go back to digging ditches and hefting bags of clay. It's really good for someone who wants to return to doubles tennis, and that's sort of the most they want to do. But it feels good, and it feels like your sports car. What if you've got your cartilage looks like this and both the joints are destroyed? Obviously, if you've tried, and even if you have x-rays that look like this, the bike, Motrin, can feel good because you may have a worn out sports car, but you may not be ready for something else. But if you've decided enough's enough, then you're probably looking at something like this. And you can look at that and tell, no matter what website you visit that promises you what false claim, you can look at that and tell that's not going to feel like your sports car. So that's a quick and dirty of sort of a spectrum. I'm happy to field questions now. I also have a little video of a knee replacement that I could show you if you guys want to see that. And I also have pictures, sort of the step-by-step of what a knee replacement looks like that answers some questions. Why don't I start with the pictures, and we'll go from there. As far as knee replacement and what is it involving, etc., obviously your day in the operating room starts out in the pre-op holding area, and here you can see slot after slot. How big is the incision? That's a misnomer. If you make a cut with your salad knife on the back of your knuckle, how big is it? Well, it depends if your knuckle's bent or not. That's a conventional knee replacement with the knee straight. That's the partial knee replacement. After anesthesia gets you tucked in and comfortable, and you could stay wide awake for the procedure. The team, I mentioned the team goes to work. So this person is wide awake, they're listening to music, and we're prepping and draping. Now you might have heard about those new custom knee replacements. I don't know if you guys have heard about the new custom knee, but so here's the knee bent, here's the knee straight. The custom knee is not a custom knee. The custom knee is a pre-measured knee. It turns out that it's really expensive to bring all this equipment to the operating room. And it turns out that it costs the hospital about $75 per tray to process all these instruments. So if there's a way to bring less instruments to the operating room, if we could just know what size you were before the surgery, the hospital could save a little money. So one thing we could do would be to do an MRI or a CAT scan before your operation and measure your knee on that, and then instead of bringing all these parts, we would just bring that one and that one and that one, and we could save on the processing. So what most of these custom knee replacements are basically a pre-measured knee. So instead of your surgeon having sizes 3, 4, 6, 9 available, they just brought size 4 plus or minus 1. But enough naysaying. So you can see all these trays that are ready, and it doesn't matter what size we find or what we get into. We've got parts available, or your surgeon has parts available to fix you. Yes, yeah, you need to be to work out. The old joke is, the orthopedic surgeon could bench press his board scores. So, but to be honest, the scrub techs are the ones doing most of the work here and lifting all this. And you can see the instruments on the right, that look a lot like the ones you buy at Home Depot or Lowe's. So here's the knee, and the patient's not feeling anything from the belly button down, or if they prefer, they could be asleep. And it's all prepped out, and we've given antibiotics. And we've given the patient antibiotics, and we do a timeout to make sure that we're not doing a breast job for someone who wants a knee job. And if you notice, we're wearing special suits. The suits that really have two advantages. Number one, they keep your stuff off of my skin. But more importantly for you, they keep my stuff out of your surgical wound. And then there's special filters in the OR and everything else. Despite all of that, despite antibiotics, cleaning your skin, and everything else, there's still a 1 in 200 or a 0.5% chance you could have an infection. And that's a really bad thing. What can you do to prevent infection? Be thin, be clean. And you can see, and a lot of times I get the question, I don't want residents to work with me, or I don't want medical students to work with me, or I don't want to, will you just do the surgery, doctor? And I try to explain them, it's really a team. You saw the team, and if you count the number of people in the room, you've got a nurse off the field over here. You've got someone whose whole job is to make sure all the instruments are there, and in case we need the special tool that goes bing, it's available. You've got the scrub tech here. You've got a chief resident here, a junior resident there, and then that's me over there. And if you look through these pictures, and these weren't staged, I handed the camera to somebody and said, take pictures. If you look, there's very rarely a time when less than 3 hands are in the wound, because it's really a complicated little thing, and you've got people holding that. So if you don't want a resident involved in your care, you don't want a medical student involved in your care, you can go to a private hospital where they have multiple technicians that are helping the doctor. Or you can go to a teaching hospital like us, or Beaumont, or St. Joe's, or Grand Rapids, where you actually have multiple doctors with their hands in the wound. But it's up to you. So here we are. We're measuring things, and that's a look at the knee. Now, this patient happened to have mostly disease on the outside of the knee. the lateral compartment. And you can see their medial condyle looks pretty good there. It's not pristine, but it's in pretty good shape. And now you can see, I don't know how well this projects, but now you can see that that lateral compartment is really sort of bone on bone. They've lost the cartilage and some bone as well. And their kneecap's a bit. And there's that power tool from Home Depot again. And what you see is most of the time, we use the patient's anatomy to sort of figure out where to put the components. So this is a little thin rod that goes inside the marrow of the bone, and we measure our angles off of that. And again, figuring out where to put things. That's ultimately the goal, is we want to put something like that in. I didn't have control over which pictures were taken, although I've deleted half of them. And then here we are, we're making some more cuts. There's those power tools again. It's really, if you have a son or a grandson that really likes tinkering, orthopedics is awesome. But again, look at how many hands are in this field here. There are multiple people helping, and a surgeon can't do a good job on their own.
You're not concerned about too many cooks?
There's only one cook. There's a few sous chefs, but there's only one cook. So, and that's how much bone we take out. And here we are, and remember I said it was a complicated little joint, and there is some art and some style to it. And, you know, a lot of it is sort of eyeballing and figuring out, and a lot of it is, you know, I think in the future, you know, when we can have people walk with a computer chip in their leg, and then it will spit out and tell us exactly where to put the parts, you know, that's the wave of the future. For right now, when we use a computer, we're basically using a computer to electronically register points on the bone, and we're still measuring and cutting with sort of this method. And there we are trying to figure out the perfect rotation for the knee. And so this thing is a device, and there's springs and there's a caliper here, and there's all this stuff, but that device is trying to determine which rotation to put the component on, the femoral component. So the rotation of this on the bone, and then it's also determining the size of the bone, and then when we like the position of it, this is just a little drill that's marking both the rotation and the position of the component. And then what we do next, oh, that's nice, it works. What we do next is we've got those, you can see the holes are pretty close to what we predetermined would be the rotation of it, so it's nice when you're right. And then this device actually allows us to take a little bit of bone off the back, a little bit off the front, a cut to blend that called a chamfer cut in front and in behind. And there we have the saw. And you know, the other thing people say is, well, doctor, I want your hand to be the one on the saw. Well, if you notice, this is actually the resident's hand on the saw, but you've got my hand that's sort of steering the saw. So they think they're operating, and that's fine with me. And there we are, and we're making the various cuts. And so when you're done, you've got this. When you're done, you've got this sort of shape where we've rounded off and removed the arthritic surfaces.
Where's the patella in that picture?
The patella is subluxed off the side, so the kneecap is right here. And a lot of times, you know, people say, well, do you do that new minimally invasive surgery? I don't care who's selling it to you. When you replace the end of your femur and tibia with metal and plastic, it's not minimally invasive. But it is less invasive than we used to do. And the kneecap, you know, the incision, you saw the incision, and you'll see this person's incision when we're all done. But the kneecap is not flipped over, and the tendon up the front is not cut. We go to the side of that. So it's less invasive than it used to be, but it's still a really big knuckle, and it's still going to hurt. So here we are, and we're using all those fun tools and toys, and just exciting looking at it. And there's the first of our trial components. So we put provisional things in to check the position of it. And then there's the rest. And now here we go, and we're checking the alignment again. So, you know, it's a good carpenter measures twice and cuts once. Well, we measure twice, cut once, and then measure again to make sure it's all right. And here we are looking at the alignment and playing with the alignment and tweaking it. And again, multiple hands, lots of hands. Now, do you put in the knee that's cemented in place or press fit in place? The knees that seem to perform best long-term are the ones that use an acrylic polymer grout. It's not an adhesive. It doesn't stick the prosthesis to the bone. What it does is fill in all the interstices between the prosthesis and the bone so that over time the bone has something rough to grab onto and to work with. Your bone is constantly remodeling, and so we sort of make a mold of the bone with this. And here you have us making a fresh batch of basically plexiglass or lucite in the operative field, sterile plexiglass. And a very thin quantity of that is put on the surfaces of the bone with what looks like a caulk gun. And here's the actual components about to go in. And there's our again, just a real thin layer of this acrylic material. Wait a minute, we have to pay homage to the hammer. Yeah. And there we go ahead.
Do all those delicate little instruments go into the autoclave?
They are processed, which is a thorough cleansing, washing procedure, dried, and then sterilized. And depending what instrument it is, it's either gas sterilized, where a chemical agent is used, or autoclaved. So, and here we are. You can see my fancy caulk gun, and we're putting just a thin layer of cement on there.
Have you ever had anyone become allergic to the knee or the caulk?
Well, the question is, I don't know if has anyone been allergic to the knee or the caulk? The real problem is that because 14% of knee replacement patients are unhappy, and because anterior knee pain after a knee replacement is common, it's hard to know. Most of these components are made with very inert metals. They're made with Vitalium alloy or titanium, and they're pretty pure, and in fact, bone tends to like titanium. If you take a rough piece of titanium and stick it up against the bone sort of goes to it. Most of your dental implants are titanium. So it's hard to say, well, you're allergic to titanium when you look at the x-ray and the bone's grabbing onto it, loving it. Most of the time when people are allergic to metal, they're allergic to the nickel that's in the metal. You know, you can't wear the cheap jewelry, that's why you make your husband buy you 24 karat gold, et cetera, et cetera. Even in patients that are allergic to nickel, when we give them, if we have someone or if your surgeon has someone who's allergic to nickel, they can actually get little discs that are made out of this Vitalium alloy, and you can clean the skin with a little alcohol to get rid of your own oils and put them on there, and most people don't react. Occasionally, we will see someone whose knee is inflamed and who's really having a fair amount of our pain associated with the knee, and when you pull fluid out of the knee, there's a lot of markers of inflammation, but it's never infected, and they get kind of a diaper rash around the front of the knee. And in those patients, there may be a nickel allergy, but having done several hundred operations every year for the last 15 years, I'm not sure I've ever really seen one. So I believe they exist, but I think more times than not, it may just be someone with a painful knee. And you can do metal testing, et cetera. As for the acrylic, have I ever seen someone allergic to the acrylic? I've certainly seen people that they must be reacting to it in some way. But again, the number of times is 2. So here we are, and we're putting all the parts. And now this is a little, the brown plastic is not what's eventually going to go in, but we're trialing that and to make sure we like the way everything is before we buy it. At this point in time, we can still say we don't like it and take out the parts and start over. But we like everything so far, and there is snapping the little piece of plastic in and irrigating and cleaning. And so this is that's the final deal right there. And there's the kneecap back over, and here we are sewing up. And another question is, do you use a glue or do you use staples? Having a wound that opens up is a big problem. I don't care so much whether it's glue or staples, and here you can see we're using basically something that's similar to super glue at the very skin edges. And it doesn't matter. And how big's the incision? Well, I'm cheating. The knee's out straight. And that's my thumb and forefinger, and it's not very big. But if you bend this person's knee, it's going to be bigger. But when it heals, it's going to be something like that. And it's pretty amazing to me we can get all these parts in and out with that small little wound. There we are, and there's a nice big bandage to make them feel like they had a big operation.
So you didn't show the clock in the background, so the elapsed time here?
This case took us from the moment of the incision until the last stitch was right around an hour and 10 minutes. But the preoperative time period, the anesthesia, the timeout, at this point in time, the surgery's not over. We still have to make sure recover, make sure the heart, make sure everything else is doing well. So if you're the first case of the day and you're scheduled to be at 7:30, you're showing up at 6:30 and you've got people poking you and talking to you and all that, and you go back to the operating room, but we don't really start working on you till 7:45, and we don't really start the operation till 8, and we might be putting the bandage on at 9:15, but you're not in recovery till 10:30. And people often ask, how long does the operation take? And my attempt to be funny is, well, it takes about an hour and a half, but I can hurry. So, and just another look at all the trays and all the parts. Was this a custom knee? No, we had every part we needed there. And then behind the scenes, if you ask about the autoclave, so each one of these lines, this tray, this tray, this tray, this tray, these are all, trays for future cases. Were they autoclaved? Yeah, these little black stripes mean they passed the sterilization. And then these are all the implants, so in case it's this size, that size, that size, they're all available. And this is looking down past all the operating rooms. Preventing infection, masks, special circulation and filters in the OR. And then most importantly, stay out unless you're needed. If we don't need you, we'd like you to stay away from the operation. Go ahead.
Do you do this type of surgery on a heavier person, or are they required to lose weight first?
Do I do this on a heavier person, or are they required to lose weight? We have some data that shows the heavier you are, the more likely you are to have a complication. Where those numbers are, it's a body mass index of 35 is a cutoff to being more likely to have an infection or a draining wound. To give you an idea what a BMI of 35 is, my BMI is about 32. I'm obese by the BMI standards. If your BMI, your body mass index, is more than 40, then I ask you to get below 40. How big is 40? I don't know. Michelle, if you're 5'6", how many pounds? Do you have your little BMI calculator? So, if you're round and short, my mom says she's just too short. If you're round and short, I'm going to ask you to get thinner. I don't mandate you lose weight unless you're in that big category. And the truth is, it's not safe to proceed if you can make yourself in better shape.
What is your weight?
My weight? I am 6 foot even, and I'm 230 pounds. And to get my BMI below 30, which would be ideal, I need to be like 212. And you can go to Google or any website and just look up, BMI calculator, and you enter your height and your weight, and it will tell you what your BMI is, and it's depressing. So again, there's another look. This is my partner. When I was done having fun in my operating room and I still had my camera, I went by and I peeked through the window and took some pictures. And then when you're all said and done, a couple hours later, you go to the recovery room. So that's it.
What is recovery and rehab like?
I mentioned that it was an enormous knuckle and that it hurts. And you need to bend the knee for you to have a happy functional outcome. So I'm not really answering the question, but if you end up with knee replacement, it's pretty sore. You can get anesthesia and blocks to make it feel good for the first day or two, but it's a lot of work to bend and straighten, and it's we see people that it's just, I think it might just be a little too much for them, and they end up with a knee that's a little stiffer than we would like. your surgeon, no matter who your surgeon is, I guarantee you they didn't leave the operating room until you had good motion in the operating room. But that doesn't mean it's going to feel good to bend it.
And just about prevention, do knee braces help? And in what situations would they help?
If you have an anterior cruciate ligament injury and your knee's giving out, like John Elway, I think John Elway had bilateral anterior cruciate deficient knees, then the knee brace can help. If you have pain in the front of the knee, remember that anterior knee pain, and you've tried everything, sometimes a knee brace, an over-the-counter knee brace can help.
Earlier, you said the left incision was for total and the right for partial, and I see both of them in this.
Right. So this was for demonstration purposes. So this is the incision that we ended up using in this patient for this procedure. But I demonstrated where the incision would be if we were going to just do the partial. And sort of that's how big it is with the knee bent, and that's how big with the knee straight. So there were more questions back. Michelle, if I'm 5'6",
217 pounds.
so if you're 5'6", you need to be less than 217, ideally. And if you're 6 foot, and she's using her little iPhone. I mean, it's stuff. And by the way, it doesn't matter if you're muscular, body mass index, your heart doesn't care if it's pumping against fat or muscle. If you're this size for this height, you need to be thinner. So 258. For a BMI of 35. So I can gain some weight then.
As far as biking, how long do you recommend a day exercise biking?
You know, I don't want you to, the question was how long should you bike? You know, obviously if you're not biking at all, then 20 minutes 3 times a week is an improvement. I don't think you're going to see a lot of benefit. You know, if you're already doing 30 minutes a day, 5 days a week, I don't think you need to exceed that. It sounds like you're putting the time and effort in. So am I missing anybody over here? Go ahead.
Do flat feet have any bearing on how your knee functions?
Well, it turns out that flat feet, where your feet go out to the side, and an abductor lurch, if you walk like the penguin, and knock knees all can go together. And if you think about it, it's just sort of the whole leg is sort of bowed that way. Whereas high arches and stiff feet and John Wayne bowed legs can go together. But I don't know of any data that says it's causative or related. You know, if you walk into your local shoeman, they'll tell you that you need the pronator or the supinator. But so if you have fallen arches and foot pain and your knees are becoming progressively more knock-kneed, then I'd go see a foot surgeon to get your foot fixed.
No, straight legs, no arch.
I don't think you're at risk for knee trouble.
So is there a new knee replacement that supposedly has serviceable parts, and what's the longevity of it?
So serviceable parts, you saw the serviceable parts. The plastic can pop in and out, and as long as the metal pieces are put in well, the parts work great forever. It's just they don't feel great. You know, as far as what the new knees are, you know, what are the new knees? You know, there's a lot of advertising out there. You know, when it comes to a big intervention like surgery, I don't think you want to be an early adapter. You know, we saw what happened with all the hip recalls. We've seen what happened with some of the rotating knee things. You know, if you see an advertisement saying it's a 30-year knee, read the fine print that says this was done in a lab, and results may vary. So,
is this replacing a knee a second time? What sort of success have you had with that?
You know, anytime you go back in to redo anything, you know, it's easiest to build your car on the assembly line the first time. Now when you take it off and put it up on blocks under the shade tree, it's going to be harder to fix. It depends how it fails. If you've lost bone, it's always going to be a little bigger deal. So it would be nice to get it done right the first time. It'd be nice to postpone it as long as possible and then to get it done right. That's not a great answer, but...
I wasn't sure how to identify myself in those categories. My biggest problem is when I've been sitting and I go to stand up, I have to wait for 60 seconds, 30 seconds before I can move, and then the more I move, it's better. What is that?
It sort of depends where the pain is. The question was, I'm not one of these categories. It's sort of when I first get up, I have to kind of wait to get going. It can be a lot of things. It can even be your hip. People that have trouble getting out of a chair, getting off a toilet, they think it's their knee because they feel it down here, but it may just even be an arthritic hip. If it hurts to sit and hurts in the front of the knee, and it hurts to get up, but then it feels better when you're on level ground, it may be that anterior knee pain.
I was told about 10 years ago that I had bone on bone. What does that mean?
Again, I don't know if it's the knee or the hip, or so. I don't want to get into your medical. If you want to, afterwards we can talk if you want.
In biking, do you bike through pain, or pain an indication?
I recommend the bike or the elliptical or the leg press, and I'm not recommending you sort of bike into pain and through pain. I think it's fairly healthy and normal to be a little sore after your workout, but if it's hurting to do it, then the most common reasons that it's hurting to do it is maybe you've got the seat too low or the resistance is too high. You don't need to be that kid pedaling uphill on a bike that's too small. You need to just be, comfortably coming in last place at the Tour de France. Pronounce my name Urquhart, unless you're in Scotland and then it's Gaelic and it's Urquhart.
Drugstores sell expensive pills targeted for people.
Joint pain, would any of that help knee pain?
Expensive pills targeted for joint pain. Yeah, I'm not a big fan of expensive things that are marketed toward any certain thing. I think if you're on a crazy diet, taking a multivitamin is a reasonable idea. I think over-the-counter things that have stood the test of time include Tylenol, up to a couple grams a day, Motrin, Advil, Nuprin as directed. Aleve is in that category. A lot of the other compounds, including the injectables, and I didn't talk about injections because this talk could be a weekend seminar, but some of the injectables really sort of fall under the compound marketed thing. If you're going to consider an injection, I think cortisone works predictably well. I think Hylogen, Synvisc, Suparts, all those lubricants are, if you really critically look at the data, it's about the same as placebo. A lot of the joint compounds, there's no proof that taking chondroitin or glucosamine or anything else, there's no proof that any of that does anything reparative to your knee. But you have patients that swear by it. Well, if you read the compound, since it's not a drug and not falling under the FDA, and since it's a food additive, you read the jar, oftentimes you'll see all kinds of things in there, like echinacea and St. John's wort, and there might be a lot of other things in there that are making your knee feel better. Having said that, if you've got an abundance of income, and if the pills are reasonably priced, and if they really do make you feel better, hey, it's better than surgery, because surgery is a big deal. I think I answered that.
I have a question regarding the impact. Like I have plantar fasciitis, and when that flares up, I find that my knee hurts more. Is there any relationship between the two?
Not that I know of, other than when things are hurting, things are hurting. So that my
knee is hurting, and then
yeah, as I said before, the front of the knee is sort of a barometer of the leg, and if your hip is hurting, or if your ankle's hurting, or if you've sprained your ankle and you're walking differently because of some other ailment, it's very common for the knee to hurt. It's not that the foot is necessarily causing the knee pain, but the way you're walking is sort of aggravating it.
Yeah, I had two questions. One, do you recommend if you have like a fallen arch or flat foot that you should get it fixed? And also if your knee gets wasted, something about a ligament, are there exercises for that?
So if your knee is giving way on you, you probably want to see someone and just make sure that it's a ligament that you can live without. Because if you just injured it 2 weeks ago and your knee is giving way, there's sometimes a brace or non-operative treatment that can help. As for having your foot fixed or other things, if only one of your 2 feet has recently stopped working and you've lost your arch and you're having pain, I would go see an orthopedic foot surgeon. And we have like Dr. Holmes or Dr. Kadaki or are one of those people. So also, I'm happy to sit up here all day and take questions, but we've got a couple of my teammates, Tam and Michelle, who gave their own personal time to come here today, and they know as much about this stuff as I do. So if you're sick of waiting for me to answer, I don't know if you guys want to break out to small groups or you want me to keep hoarding the stage. So prevention. Stay thin and pick good genes.
Thank you very much.
Oh, you're welcome.